Hello and welcome everyone. We have seen that CO2 has got a very critical role in the management of ICP. Sometimes even more than oxygenation, blood pressure, heart rate, CO2 has a very critical role. And we have seen that various types of management strategy are used. For example, in cardiac arrest, we try to increase the CO2. In brain injury, we try to reduce the CO2. So there is a lot of confusion and doubts as to when and how we should titrate the CO2 in patients with neurological damage. Adequate cerebral oxygen delivery is crucial to prevent further brain injury. Now this is the central for any kind of a acute brain injury. The level of carbon dioxide in the blood strongly affects the blood that is flowing through the brain. This is called the cerebral blood flow or the CBF. So this CBF is directly affected by the level of CO2. Now relationship between the CO2 and the cerebral blood flow is there is a link is almost linear within a CO2 range of 20 to 80 millimeters of mercury. And for every 1 millimeter increase in the CO2, the cerebral blood flow increases by 3 to 6%. Now this is very crucial. A 1 millimeter change in CO2 is a very quick and fast change, and it can happen very easily and very quickly. So increase of 6% or say even 10-20%, which can be achieved by just 1 to 3 change in the CO2, can be very crucial, especially in patients who have a raised ICP. There a 20% increase in the cerebral blood flow may be the difference between life and death. And for every 1 millimeter decrease in the CO2, you get a drop of around 1 to 3%. So how much we are able to reduce the swelling in the brain, that also is dependent on the CO2 clearance. Now what is this CO2 reactivity? The brain's response to CO2 is less in older adults and when the patient actually has a severe brain injury. So it's not always that linear and it can get distorted, which may make our management much more difficult. The grey matter in the brain is more responsive to changes in the CO2 compared to the white matter. So the grey matter is more affected by CO2 changes than the white matter. Now how CO2 change affect the brain? The CO2 quickly crosses the blood-brain barrier, changes the pH around the blood vessels of the brain. So the pH around the blood vessel changes, which actually results in the change in the blood flow. A high CO2 causes cerebral blood flow to cerebrospinal fluid to become more acidic, and this leads to widening of the small arterioles, that is the pial arterioles, increasing the cerebral blood flow and the brain blood volume. This may increase the ICP, especially if the brain can't compensate for any further increase in the blood supply. So this is how the CO2 affects your brain. And if we look at hypocapnia, this will make the cerebrospinal fluid more alkaline, causing vasoconstriction, reducing the blood flow and the blood volume. Helps in lowering the ICP. This, however, is sometimes used to manage high ICPs. So if you look at the diagram, as you can see here, the CO2 from the perfusion, it enters the cerebral blood flow and the circulation in the brain, where it affects the pH of the blood vessels, that is here. As it reaches the blood vessels, it increases, then it causes acidosis. If it decreases, it causes alkalosis. Now this perivascular alkalosis will cause vasoconstriction, causing ischemia, and perivascular acidosis will cause dilatation and hyperemia. So you can see the image, alkalosis, low PCO2, vasoconstriction, acidosis, high CO2, vasodilatation. So in this schematic diagram, you can see a relationship between the cerebral blood flow and the arterial carbon dioxide. As you can see here, there is almost a linear relationship between 20 to 80, which is the range where we actually work. Beyond that, it flattens out. So the relationship is almost linear. And next is the brain elastance. If the elastance of the brain is low, that is increased CO2 and increased blood flow causes a very small rise in the ICP. However, when the brain is very tight, the elastance is high, the brain is very stiff here. So a small change, a similar change in the blood volume, that is the blood flow, will cause a massive rise in the pressure. So this is very, very important concept that you must understand. The compliance, the elastance of the brain, once it becomes more stiff, the pressure change skyrockets, and this can be a matter of life and death. So PCO2 has a very, very critical role to play over here. So let's first see how we can use it in managing various brain conditions. First is acute brain injury. For acute brain injury without raised ICP, keep the PCO2 around 35 to 45. If, however, the ICP is elevated, you can lower the PCO2, but this should be done very, very carefully and only as needed. Evidence from the studies is coming from the INEO trial, where we have around 1400 patients, which showed a U-shaped curve of the outcome. That is, majority increase in CO2 is less than 32 and more than 35. If that happens, then the mortality increases. 32 to 45, you have that U-shaped curve. The highest risk of death is with PCO2 below 26. So as the vasoconstriction increases, the damage to the brain more increases, you compromising the blood flow. And best outcome is PCO2 in the range of 35 to 45. So this is why we are using this. 1400 patients, U-shaped curve. As you go down and go up, your mortality is increasing. Next is traumatic brain injury. You have two approaches. First is the Seattle consensus, where you have the tier 1, where the low PCO2 is targeted, 35 to 38, and then you have tier 2, where mild hypocapnia is done, that is 32 to 35. Next is the Brain Trauma Foundation guidelines. They do not routinely lower the PCO2 below 30, and a clinical trial showed that keeping the PCO2 at 25 plus minus 2 for a long time after the traumatic brain injury worsens the long-term outcome compared to somewhere where we keep it normal, that is 35 plus minus 2. The real world practice shows that PCO2 may vary widely between the hospitals. So this is something we must keep in mind. It is usually something which is neglected, but it must be kept in mind that PCO2 has got a critical role in traumatic brain injury. Brain monitoring of the oxygenation, if available, use the oxygen monitoring devices to decide how much and how long you want to lower the PCO2. This helps prevent excessive reduction of the blood flow and oxygen. Investigational approaches are like newer trials, that is Bonanza and Boost 2, are testing whether mild hypercapnia, that is 45 to 50, can help in improving the brain oxygenation if the ICP is normal. So the whole idea is that as we vasodilate it, the blood flow is going to increase, and once increase the blood flow, we will get better outcomes as the healing will be better. So this is the whole hypothesis. Let's see what they find out. And this method should not be used unless you have invasive brain monitoring available, as it is still experimental. As you can clearly see, this is something which is very, very dangerous, especially if the ICP is raised. So without invasive brain monitoring, do not try this in traumatic brain injury. Next is PCO2 targets in stroke. There is no specific guidelines to exactly how much should we keep the targets in ischemic or even hemorrhagic strokes. Most recommendation is to align with the traumatic brain injury guidelines. The general recommendation, however, would be to keep it same around 35 to 45. And ischemic stroke, blood flow to the penumbra is already reduced. So Hyperventilation can cause steal phenomena, diverting blood away from the healthy area towards the phenomena. However, routine hyperventilation is not something which is recommended because prolonged low PCO2 can expand the size of the stroke and worsen outcomes. So it's a, as you can see, it's a very delicate thing, not something so simple and easy that every time you will hyperventilate, you are going to increase the blood supply to the penumbra. It can also increase the size of the stroke. So this is still experimental stages, not much is known. So keeping it around 35 to 45 would be the best thing for us. Next is subarachnoid hemorrhage. Patients often develop spontaneous hyperventilation here. Usually these patients tend to have a hypocapnia. Hypocapnia will lower the blood flow, which is risky here, especially when the patient has a risk of vasospasms or delayed cerebral ischemia. So this must be very important and kept in mind, that PCO2, the hyperventilation and the risk of vasospasm. Simply breaking the PCO2 is normal to is not always safe due to the risk of sedation and masking the neurological changes. Individualized management is needed. Controlled hyperventilation up to 60 to some small studies have improved the blood flow and oxygen without raising the ICP in severe SH. Now, the patients with NEO subgroup where mild hypocapnia increased mortality while hypercapnia did not. So you can try hypercapnia here, but then it's quite delicate. Controlled moderate increase in the PCO should be useful for a select group where you think that the delayed cerebral ischemia risk is very high, but we need definitely much more research on this aspect. But this is a very important thing and a very common thing, so we need to keep that in mind when treating such patients. Regarding intracranial hemorrhage, same thing as before, 35 to 45. Avoid hypercapnia here because large bleeds you may get a mass effect. These patients have poor brain compliance, so even a slight increase can be dangerous over here. Finally, post cardiac arrest, the guidelines recommend the same, that is 35 to 45. The TAME trial, which had around 1700 patients, showed that rising the PCO2, that is 50 to 55, did not improve survival or brain function compared to keeping it normal. Now, this is likely because the patient often have reduced brain responsiveness to PCO2 after cardiac arrest, and you do not get that increase in the cerebral blood flow. After circulation returns, the brain blood flow temporarily increases for 10 to 30 minutes, then drops to a low flow state for longer time. In this low flow state, low capnia can easily cause further brain ischemia. That must be kept in mind. So strictly avoid any kind of a PCO2 less than 35 after resuscitation to prevent the worsening of the brain injury. To summarize, for most acute brain injuries, you keep it 35 to 45. Mild hypocapnia can be used briefly and only for crisis if you have very high ICPs, but this should be done for short periods and not for long. Controlled hypercapnia is still being studied and not recommended for routine use in any of the practices, but then it's an area of important and research, especially with SAH patients, post cardiac arrest patients. Thank you for your patience.